Hello, my name is Jacob and I am an ICU registered nurse, also termed a critical care registered nurse. I'll get to that a little bit later. This video is on behalf of the Nurse Break and is essentially about the life of an ICU nurse, what it takes to be an ICU nurse, the education background, and kind of a little bit of a story around me anyway. I've got a few little questions and stuff to kind of cover. I'll probably go off a bit of a wild tangent and whatnot, but hopefully if these questions will kind of give you better idea and insight into actually what an ICU nurse does and the things that we do, why we do it, and just give you a little bit of an insight and hopefully encourage you to become one. So how I became an ICU nurse was I did all my training back in New Zealand, and initially I wanted to do mental health nursing. I did my mental health placements in units. Didn't really find it interesting, wasn't my thing. I realized how more challenging it was than I realized. I then did an accident emergency clinical placement, kind of loved that. And then in my final 6 months of training, we had to do a transition to practice placement, which involved 10 weeks of clinical placement on top of 2 weeks of theory to prepare for a registration exam. So in that 10-week clinical placement, I was a student in a tertiary ICU in Auckland, and this unit covered ICU HDU, and I did 365 hours over those 10 weeks, qualified with full registration. And that actually drove me to be a ICU nurse essentially, but I just didn't know the correct career path and wasn't sure actually how to get a position in an ICU. But I think the most valuable thing about doing a clinical placement in ICU was the first 4 weeks I was kind of drowning. The first 4 weeks I didn't really understand what's going on. There was pretty much alarm bells going off every left, right, center. There was just so much machinery, so much monitoring. It was extremely daunting, traumatic actually. But I think after 4 weeks you get comfortable and you get into the swing of it, and it kind of gets a little bit more comfortable. So yeah, once I completed that placement, I got notified that I had a accepted position for another tertiary hospital in a critical care complex, which was essentially ICU HDU. And I spent the first 12 months of my nursing career in a ICU HDU. And then I subsequently got itchy feet, decided to travel a little bit. And that's where I've been for the last 5 years in Australia. Predominantly ICU and a little bit of other things, but had quite a nice journey really. I think ways to get into ICU. There's quite a few different paths. You don't have to. I don't think there's many new grad positions anymore in ICU. One way, which I would probably strongly suggest, is go the regional pathway. If you work in a regional hospital, they really value nurses that are willing to jump up and willing to take the necessary steps forward to work in any area available. So I think regional hospitals would be an amazing opportunity to learn the ropes, even learn a little bit of high dependency, learn a little bit of emergency medicine, and then you can move forward to tertiary in the major metro cities. The major metro cities aren't the be all end all. The regionals have a lot to offer, and I would strongly recommend it. Other ways to get into an ICU, and a few hospitals in Australia I've noticed do programs if you've got 1 or 2 years experience as a nurse in any field really, mental health, community health, prisons, hospitals. They do foundation programs, so they bring in these semi-experienced nurses and train them up over a year, build up their skill set, and then these guys seem to get permanent contracts at the end. So even if you think you don't have the necessary skill set, just try anyway. Because what you learn in, say, an aged care ward, what you learn in a oncology ward, essentially is what we would do in ICU. We specialists in everything, but have to be, we have general skill set, but we need to know a little bit about every specialty imaginable, because whatever comes through the door, we have to do. So whatever skill set you bring from other areas, bring it, and we would love you for it. In terms of extra education, I think if you spend the first 1 to 2 years in an ICU as a nurse, it's all about consolidating knowledge and kind of learning the ropes, learning the patients, learning the equipment that we use, learning the medications that we use. And then from there, probably in your 3rd year, maybe even your 2nd year, that's when you go back to uni, do your postgraduate qualifications. So some programs do, so some hospitals in Australia also do critical care students. So these are qualified ICU nurses. These are qualified nurses with ICU experience. The hospital supports them to go back to uni to do their grad cert in critical care nursing. And then from there, that's when they're termed critical care registered nurses like me. I did my graduate diploma in critical care nursing, and I believe the academics and the research and everything that you do in your academics builds that skill set and the theoretical knowledge in the background, which actually helps you clinically, because you can go, okay, I saw this interesting case in a journal article. I'm kind of seeing a little bit of my patient in front of me. So therefore, this is what I think needs to happen. It also helps you advocate for your patient and actually communicate to the treating team and communicate to people, which is amazing. So yeah, that's one thing. And I think so I think academically it pays to do your postgrad. I think most hospitals in Australia are starting to move to it being essential, not mandatory criteria, but I imagine in the next 5 to 10 years, if you've got your critical care cert, diploma, or even your master's, that's going to get you a foot in the door. So it's worthwhile to have. But again, join one of those foundation programs, build and consolidate your knowledge on the floor, and then talk to your educators and go from there. But as I said, any skill set from other areas like aged care, mental health, those are really valued. ED, surgical wards, because the things that we have to do in ICU are, we cover every specialty. And as ICU nurses, there's no way that we can know everything. And even nurses that have been around the block for 20 years still don't know what's happening on some things. So this is one area of nursing that I love, because it's very varied. It's got a lot going on. And there's a lot to learn and a lot of challenges. We're very independent nurses, which is amazing. So one of the other questions that I think there was what type of patients do you care for? And I think I've covered that a little bit. So in the ICU I currently work, we cover every specialty imagine, known to man really. We get post-operative patients in hypertensive states, shock, severe infections, patients that have had long surgeries such as coronary artery bypass grafts, burn surgeries, orthopedics, any surgery that is really long, complex, there's a lot of blood loss, and to wake and wean them from sedation and analgesia is just a little bit tricky, is a little bit challenging. Other patients we get is from ED, for patients that require blood pressure supports, management of severe infections. Any patient that's not safe to be managed on the ward essentially will come to us. The difference between high dependency and ICU is in high dependency, they need a little bit of extra surveillance. They're not yet safe to go to the wards. We're just holding on to them to manage a few little things. They're managed one nurse to two. In ICU, it's a different story. They require higher level surveillance. Some of the equipment and medications that we do have to give require one-to-one nursing. Occasionally, you'll get 2, maybe 3, maybe 4 nurses to one patient if they're really crumbly and a little bit requiring a little bit extra support. Some of the things that we do, which makes the area challenging yet fascinating, and as I said, we are a very independent branch of nursing. We are very open, honest, and highly communicative with our doctors. It's a very sibling type relationship in ICU. We can go up to our doctors and we can go, okay, this is what I think is going wrong. They trust us and our knowledge and our skill set to tell us what we think. We can also guide, and it's a similar story. The doctors can come up to us and go, oh, we need to do this treatment. But if you ask them, oh, why are you doing that? They'll actually sit down and explain it to you. So the doctor's really good at educating us. And it's a similar story. We can go back to docs and tell them and, have a bit of an open chat to them. And I think that's one thing that is great about ICU, is that open sibling type communication. And there's a lot of humor. We do deal with a very traumatic side of nursing, and it's a very traumatic, abnormal side of nursing in terms of what we have to do. And I think that's why we have such a good relationship with everyone that we work with. And other things that we do work with are breathing machines. So we do have breathing tubes, also known as ETTs, tracheostomies. So if a patient can't maintain the airway, they've got severe respiratory failure, severe infections, essentially anything that's going on that compromises airway, we will put a breathing tube in and manage their breathing. Now, one of the main misconceptions of this is that we're doing all the work, we're sustaining life with that. Now, yeah, we are in some way sustaining life, we're sustaining their airway. We can wake patients up off sedation and get them eye-opening. They can write on pieces of paper. They can semi-communicate to us if it's safe, of course. And this is another side of nursing that we deal with is we've got a lot of drugs that we titrate in terms of sedation. So if the patient's not comfortable on the breathing tube, we'll increase sedation, we'll increase analgesia, we'll increase these drugs based off what we're seeing, what we're assessing, and go from there. Other things, as I said earlier, hypertension is our main issue, especially when we're giving all these sedation and analgesics. We've got a lot of drugs that we can use to prop people's blood pressure up, especially when they're in severe infection. There's a lot of fluid shifts and they get a hypotensive state. So what we do is we give these medications. We titrate a lot of things based off what we're seeing in front of us and based off what we're seeing on the monitor. Again, we have a lot of numbers, a lot of machinery that we look at, but it's also not just relying on numbers and also looking at patient going, okay, my numbers on the machine are this, but it doesn't really relate to my patient because they're doing this. So a lot of what we do, even, and I think there's one misconception as well, is that we do a lot of sitting down one-on-one, so therefore we're a lazy branch of nursing. But what we're doing when we're sitting there is we're looking at our monitors, we're looking at our ventilators, we're looking at our patient and all analyzing everything that's coming towards us. So we're looking at urine output and going, oh, that's a little bit low. Why is it low? Blood pressure's a little bit low. Do I need to get, are they a little bit dehydrated? Are they showing signs of fluid loss? So there's a lot of assessment, a lot of analyzing, and a lot of eyeing things out, just trying to understand what's going on. So we do a lot of things from our chair, which is like a Microsoft computer. We process a lot of data, and then we figure out what to do next with that. I think the one thing that people need to know before they come to ICU is that it may look scary, but as I said earlier, I think it takes about 4 to 6 weeks for you to feel comfortable. And I think probably at least another 4 weeks after that to feel a little bit more confident. There's no point coming in all gung-ho knowing everything, because not everyone knows everything. And you've got a lot of experienced nurses, you've got the critical care registered nurses, you've got a lot of educators, you've got a lot of people that know stuff. You've got the doctors who are open and willing to educate, teach you and guide you through what's going on. So always ask for help. I think, as I said earlier, I think there's nurses that have got 20 years of experience. They still go up to someone else and go, oh, I don't know about this procedure. Can you please show me? Or I don't know about this. Can you please explain it? Because we all come from different areas. We come from different cultures. We come from different areas of training. So therefore, we've all got a little bit of bits and bobs of knowledge that we can share. And that's one thing amazing about ICU nursing, is that we love talking about things and we love guiding, teaching and doing. I think the other misconception that I can think of my area is that we're probably 99% deaf, 1% probably saving. I think deaf and dying is a minority of our working day. We do get on the knife edge of it though. And I think the majority of what we do is just stabilizing, making sure that things are safe and trying to get people to a state where we can get them out of ICU, get them to rehab, get them in a somewhat stable position. Be it through antibiotics, be it through ventilation, be it through medications and support and just giving them rest. So a lot of what we do is trying to stabilize and trying to make things right again. As I said, it's a very abnormal type of nursing, because we have to titrate analgesia, we have to titrate sedation on infusions, we have to titrate blood pressure medication. Sometimes we might even have to do dialysis in our unit. We have to manage a breathing machine. So a lot of what we do is, even though we're one-to-one with those patients, sometimes it does feel like we've got 5 ward patients in that one bed, because the amount of stuff that we need to analyze, assess, do, administer, it can be quite overwhelming. But it does take you a couple of years to kind of get into a state where you can start running and just doing it naturally. And I think as a student, if you did come into our area, always ask for help. there's always someone experienced that knows what's going on, or somewhat knows on, or pretends to know what's going on. But I think that's an area of nursing we're all more than willing to talk to you, all more willing to debrief. We're willing to just have a chat. Even if you want to talk about your cat, just have a chat to us. I think one thing that we need to work on in ICU definitely is debriefing and just talking about what's going on with the day. There is a lot of times where we've normalized a lot of situations, and it's only because we've been in the field for too long, or we've seen it too often, so therefore we've normalized what we see. And there's not as much debriefing as what should happen. So do tap us on the shoulder and ask us questions. I'm sure we're more than happy to waffle on. In terms of interesting pieces of equipment, I think everyone's seen a picture of an ICU bed space and sees 20 million machines. They're all fascinating, and that's one great thing about ICU nursing is you could be a dialysis nurse one day, you could be a respiratory nurse, you could be a cardiac nurse one day, trauma, neuro nurse. So in that one bed space, you could easily be 50 different specialties, and you'd be switching from neuro 1 minute back to dialysis the next minute to cardiac the next. So in that one bed space, you can be 20 million specialties. But again, it's not looking just at your numbers. Look at the patient, go, okay, what does this mean? Why is my patient doing this? Is it because of this, that? And I think that's one thing that I love about ICU is that you're 20 million specialties. You get to dabble in any field imaginable. And there's a lot of technical challenges. And you do learn a lot. And I think it will take a bit of time to learn it, but the amount that you do learn, you'll be fascinated. And I think that's a little bit about ICU nursing. It's once you get into the bed space that you understand that you might like it, you might hate it. Again, give it 4 to 6 weeks, and I'm sure you will love it. In terms of what's next for me, I'm planning on maybe going back to masters next year. Haven't decided what or when. I am curious about education. I do love waffling and teaching, but I think that's the majority of ICU nurses. We do love teaching. We do love waffling. And yeah, I think just take it easy and breathe, relax. As a new grad, it will take you I'd say take a good 4 to 6 months to feel comfortable in any specialty. And if you come to ICU, it will take you a bit longer, but there's always someone behind you, guiding you, teaching you, and trying to get you into the correct spot. So yeah, please join ICU. And if we do see you, remember we love chatting and we will love to educate.